our first presenter for today's session is Carrie Haney, and Carrie joined Johns Hopkins after earning her bachelor's degree from Carnegie Mellon in International Relations and Politics. And today, Carrie is going to be presenting her master's essay entitled, "Do Covert Contraceptive Users Engage with the Health System Differently? Understanding Women's Care Experiences in Kenya." So Carrie, I'll hand it over to you. You can go ahead, unmute, share your screen, all that, and kick us off for today's session.
Great, thank you for that introduction, Celia. Okay, so hi everyone, I'm Carrie Haney, and I'm excited to present to you all my master's essay, "Do Covert Contraceptive Users Engage with the Health System Differently? Understanding Women's Care Experiences in Kenya." In this presentation, I will go over background information relating to covert contraceptive use, my methodology, the results of my data analysis, and discussion. And as a quick note, I'll be using the term women to stay consistent with the labels used in previous literature, but I recognize that not only those who identify as women utilize contraception. Covert contraceptive use is a practice of using contraception without the knowledge of one's partner and is used by women to achieve their reproductive goals. This practice is highly relevant in sub-Saharan Africa because of the high value placed on women's fertility, expectations related to motherhood, and concerns about contraceptive side effects, which may inhibit women's ability to use contraception overtly or using contraception and your partner knows about it. Common reasons for covert use include concerns about partner disapproval of family planning, discomfort in discussing contraception with their partner, and fear of partner retaliation and violence. It may reflect women's attempts to attain reproductive autonomy. Covert users have been found to have lower levels of educational attainment, come from poorer households, and experience intimate partner violence and reproductive coercion. These characteristics can also indicate women having less decision-making power within their couple. Covert users may face several barriers in relation to the health system. Women using contraception covertly may prefer certain contraceptive methods because they are easier to hide, such as injectables, implants, and IUDs, which can thus limit their options when choosing a method. While there is limited understanding of differences in counseling based on covert use status, contraceptive users, including covert users, may not receive comprehensive counseling from their health provider after choosing their method. This lack of information puts covert users at risk of being exposed because side effects, like spotting in between cycles, could be difficult to conceal. Additionally, financial burdens may also prevent covert users from continued contraceptive use, as many covert users lack adequate financial resources separate from their partner to obtain their method or attend appointments for health services. Due to the hidden nature of their contraceptive use, covert users may rely more heavily on the health system to manage their use. Therefore, access to the health system and support from health providers is essential to covert users' achievement of reproductive autonomy. Currently, limited research has explored in depth how women using contraception covertly interact with the health system. This analysis seeks to address this gap by exploring how covert users experience contraceptive care from the health system according to where they acquire their methods and how they are counseled about their contraceptive methods. For this analysis, we used survey data from Performance Monitoring for Action and their Phase 2 female cross-sectional survey implemented in Kenya in 2020. This survey includes questions to learn women's fertility preferences and behaviors, family planning access, choice, and use, and quality of family planning services. We restricted our sample to survey respondents who reported that they are not currently pregnant, are sexually active, in using modern contraception, and are aged 15 to 49. Our final sample consisted of a total of 3,967 survey respondents. Our independent variable was covert use status. Survey respondents who said that their partner does not know that they are using contraception were categorized as covert users, while those who said that their partner does know were considered overt users. Our key dependent variables reflected contraceptive users' experiences with the healthcare system. We measured facility type from which the respondent received their current method and receipt of the Method Information Index Plus, or MII Plus, which I will describe in the next slide. Finally, we included sociodemographic characteristics, which are age, marital status, educational attainment, residence, and wealth in this analysis, as well as type of contraceptive method, which we categorized as either provider dependent or provider independent. Provider-dependent methods were modern contraceptive methods that required the involvement of a provider, like the implant, injectable, and IUD, while provider-independent methods do not require involvement of a provider, like the pill, patch, and ring. As I mentioned before, the key outcomes were facility type and MII+. For facility type, respondents reported where they received their current method, and these facilities were categorized as either a public facility or a non-public facility. The MII+ is an indicator used as a proxy measure for understanding the quality of contraceptive counseling. It reflects the delivery of basic information during counseling by asking respondents to self-report 4 components of care: whether or not they're informed about 1, other methods of family planning, 2, possible side effects of their current method, 3, how to manage side effects, and 4, the possibility to switch to a different method if they do not find their current one suitable. We measured receipt of the MII+ in 3 ways: by each of these 4 components as a binary measure, as a continuous score ranging from 0 to 4, reflecting the number of components respondents received, and as a binary score that reflected whether respondents received all 4 components of care or not. In this visual, a value of 0 means that the respondent did not receive that information, and a value of 1 means that the respondent did receive that information. For our analysis, we used descriptive statistics to describe sample characteristics, distributions of covert use status, facility type, where method was obtained, and receipt of MII+ components. We then calculated bivariate associations between covert use status and sample characteristics, facility type, and MII+. Finally, we calculated associations between covert use status and our key health system outcomes while adjusting for potential confounders, which were our respondent characteristics. This table describes women in our sample stratified by covert use status. Some key differences we found in our sample are that covert users were disproportionately younger, more likely to be from low-income households, and unmarried compared to overt users. This figure presents distributions of facility type by covert use status. The light blue is a proportion of respondents who reported receiving their method from a public facility, while the dark blue is a proportion who received their method from a non-public facility. About 77% of all respondents received their method from a public facility, and around 23% received their method from a non-public facility. This distribution was similar among covert users and overt users, and bivariate analyses did not find that covert use status and facility type to be significantly associated, suggesting that covert use status does not impact where contraceptive users receive their method. Now on to the main results. This figure presents counseling outcomes by covert use status as measured by the MII+. Along the x-axis, we have each of the MII+ components individually, and the binary scores on the far right. Each bar represents the proportion that received information from the MII+. The total sample is in gray, covert users are orange, and dark purple is overt users. The brackets over the covert and overt bars reflect whether the difference in the outcome is statistically significant when comparing between covert and overt users. From this figure, we see that covert users received information from the components of the MII+ at lower rates than overt users for 3 of the 4 components and the binary score. Now turning to our multivariate regression models, this table presents adjusted associations between covert use and aspects of health service delivery, which are adjusted for the respondent characteristics. After adjusting for these potential confounders, we again found that the facility type was not impacted by covert use status. And in terms of the MII+ individual components, covert users had 26% lower odds of being informed of other methods and 34% lower odds of being informed of side effects relative to overt users. In looking at these components holistically, covert users scored lower than overt users in the continuous score, and also had 31% lower odds of receiving all 4 components during contraceptive counseling compared to overt users. This table provides evidence that covert users receive poor quality counseling compared to overt users. From our key findings, we can postulate that, in terms of facility type, public facilities are commonly utilized by Kenyan contraceptive users. This may be a reflection of the health facility landscape in Kenya, but we do not explore that in this analysis. Regarding quality of contraceptive counseling, this evidence that covert users receive poor quality contraceptive counseling can pose great risks to covert users. Lack of essential information during counseling could lead to covert use being exposed to the women's partner, which could then lead to negative consequences such as dissolution of partnership, withdrawal of financial and social support, and violence, including intimate partner violence. We recommend that healthcare providers commit to providing comprehensive, high-quality counseling to all who seek family planning services, regardless of covert use status. This analysis is subject to certain limitations. We restricted the sample to Kenyan women ages 15 to 49 who reported not currently being pregnant, who are sexually active, and are currently using a modern contraceptive method. Additionally, covert use status, as well as the components of the MII Plus, are self-reported proxy measures and may be subject to biases such as recall bias and social desirability bias. Further research should be performed to gain a better understanding of health service delivery factors and covert contraceptive use. We could explore these relationships in other geographies, such as other low and middle income countries, to see if quality of contraceptive counseling differs systematically for covert users. Additionally, we see that there are differences in how covert users are counseled at the time of method initiation, and there may be further differences as covert users are trying to manage their method. So I'd like to give a special thank you to Celia Cart for being such an involved master's essay reader and a valuable mentor throughout this process. And also shout out to Pop Fam, my family, and all my friends for being my support system throughout my time at Hopkins. I truly could not have done it without you guys. Thank you all for listening.
Wonderful job, Carrie. What a great presentation to kick us off today. Oh, you already have praise and questions coming in the chat. Maybe let's first take a live question from the audience, and then we will go to this one in the chat. Anya, I see your hand first. Do you want to go ahead and ask your question?
Yeah, thank you. Congratulations, Carrie. That was a great presentation. So I was wondering, in your view, what are some ways that Kenya can increase the percentage of people who receive the full I think it was MII plus, was it?
Yeah. Well, thank you so much, Anya, and thank you for your question. It's a pretty good one. And although we don't explore the specific policy recommendations that could allow for increase of MII plus receipt, I'm a big fan of high quality data and how useful it is in the decision-making process. So I believe that if Kenya updated their contraceptive counseling training procedures and included the MII plus components or the indicator itself, and also included in their data collection processes received the MII plus, that it would increase. But right now, Kenya should definitely continue collecting data on the MII plus, either through PMA or other avenues, because it is a fairly new indicator, but it's the best one we've got so far.
Great.
Thank you.
Thanks, Anya, for the question. I'm going to go to the one in the chat and just have, prioritize student questions first. There's a question from Jagruti in the chat. It says, "Hi, Carrie, thoroughly enjoyed your presentation. I was wondering why there was evidence that covert users receive the components of the MII plus at lower rates for all aspects except side effect management."
That is a good question. So if you guys remember, all three components of the MII plus were found to be received at lower rates among covert users compared to overt users, except for the side effect management. And that is actually a data collection quirk, because during data collection, the surveyors only asked respondents if they receive information on the side effect management, if they said yes to receiving information on the side effects themselves. So this finding could indicate that side effects and side effect management are the components that are usually given together, but I can't say for sure based on this analysis. Either way, it's still concerning that covert users systematically receive lower quality counseling and lack information on on their method.
Great, thanks, Carrie. So to the hands now, Dana, do you want to go ahead and ask your question?
Hi, great work. Thank you so much for this presentation. I had a few thoughts, but I'll pick the first one. So we don't have info on whether the provider knows the woman is a covert user or not. So I was wondering, like, what's the mechanism if the covert users are getting worse quality of care, but the providers may not know that she's covert? Like, why do you think it's because they're covert? Like, what do you think? What's the mechanism there?
So
other
in
thing-
my reading, first of all, thank you for the question, and I'm really glad that you enjoyed the presentation. But in my pre-reading, I did see that this is not well understood, first of all, so there's not much evidence I can base this off of. However, in previous studies, they found that providers actually, they were told by the patients that they want to have their method concealed. So for example, covert users, they did not want to bring home the health system or health appointment card that shows that they went to the health provider and actually received health services and healthcare from them, just so that their partner would not see that they were receiving family planning services and they did not know about it. So this is definitely something that I personally would be very interested in for future research, because we just don't know exactly the continuum of care from initiation to discontinuation, the full experience of covert users. However, what we do know right now is that perhaps sometimes the patient does disclose to the provider that they want a more concealed method, or maybe they do it in more covert ways of expressing their covert use intentions. But this is definitely a topic that I would like to learn more about, and I would be happy to look further into it.
Thanks, Dana. Thanks, Carrie. Haley, I saw you had your hand up earlier. Do you want to ask your question? Do you want to put it in the chat? And if you put it in the chat, then we can, I see Shannon has her hand up.
Yeah, great job, Carrie. I just wanted to ask, because you said that one of your limitations was limiting your sample to non-pregnant sexually active women using a modern method, but I don't think you said why you listed that as a limitation. So I was just wondering if you broadened your sample, what do you think that would mean for your analysis, or can you just describe why you think that's a limitation? Thanks.
So I think restricting this sample was more of a practical thing. It's a practical decision that we made, because if they're currently pregnant, they're likely not going to use contraception, and then their chances of being a covert user at the current time of data collection would be 0. So we were really only focused on those who were using contraception at the time of the survey, and are sexually active, so they have a reason to use contraception, and also that they're using a modern contraceptive method, because then they would be more likely to go to a health provider. And what we're really looking at is interaction with the health system, as opposed to using a traditional method.
Thanks.
Yeah, so that makes sense. So is that a limitation? Because it sounds like a good thing to make those decisions.
I think it could be a limitation, especially because we don't include further exclusion criteria. So we still don't know the additional nuances of covert users and what population makes up covert users. There's a lot of previous studies that have found associative factors with covert use, but some of these findings are kind of contradictory, so the nuances might be more complex.
All right, our second presenter is Foujan Moghimi, and Foujan came to Johns Hopkins from Caldwell University, where she earned her Bachelor's of Arts in Biology and Psychology. She is going to be presenting today on her master's essay entitled "A Scoping Review About the Effect of Abortion Access on Women's Wages and Employment." So take it away, Foujan.
Hi everyone, my name is Foujan Moghimi, and today I will be presenting my master's essay, which is a scoping review about the effect of abortion access on women's wages and employment. First, we will cover the background and landscape of abortion and economic outcomes. Abortion access plays a significant role in shaping women's wages and employment opportunities. The ability to make decisions regarding reproductive health care directly impacts a person's economic well-being and professional advancement. Historical studies like the Turnaway study was pivotal in showcasing the importance of abortion access as a determinant of women's health and economic outcomes. Since 2016 and the completion of the Turnaway study, however, the legislative landscape surrounding reproductive health has changed drastically. Of particular note, Roe v. Wade was decided in 1973, which gave women the right to an abortion under the Privacy Clause on a federal level, while Casey v. Planned Parenthood was decided in 1992, which affirmed the right to an abortion under Roe, yet gave states the power to regulate abortion as a means to protect the life and health of the mother and fetus. As many of you may know, this landscape has been changed given the recent Dobbs decision, which removed abortion rights on a federal level, thus completely changing abortion access for women across the nation. The purpose of this scoping review presented today is to build upon previous studies and examine more recent legislative changes in reproductive health and its relationship with women's employment and wages. For the purpose of this presentation today, the general term woman is defined as birthing individuals and birthing people, but the researchers acknowledge that the term woman does not encompass the entire population that abortion access affects. To reiterate once again, the main focus and objective of this study was to examine the relationship between restrictions on abortion access and women's employment and wages. Now moving on to the methods. The review involved developing a search strategy with the assistance of a library informationist and focused on the themes of abortion and employment. Initially, only employment-related mesh terms were included, but due to a lack of relevant articles, income and wage-related mesh terms were added. The search strategy excluded socioeconomic factors and educational attainment. The search was conducted in PubMed on March 29, 2023, and the results were imported into Covidence, which is a literature review management program. 3 independent reviewers, 2 at the master level and 1 at the PhD level, conducted a double-blind screening of titles and abstracts for potential inclusion, resolving discrepancy through discussion. Full text articles were assessed for eligibility based on predefined criteria, and decisions were documented in Covidence throughout the process. The inclusion criteria for studies in the scoping review required them to be peer-reviewed, published in English, and focus on the impact of abortion access on women's wages and employment. The review spanned 2 time periods. One, 1970 to 1974, and the second one is 1992 to 2023. The early period was chosen to examine the economic effects of limited abortion access prior to Roe v. Wade Supreme Court case, while the later period explored the impact of abortion restrictions and undue burden policies following the Casey v. Planned Parenthood case. The team adopted the broad definition of abortion as pregnancy termination before 20 weeks gestation, according to the CDC and WHO. The search strategy included medication-induced abortions and focused on abortion access obstacles, such as distance, cost, and insurance coverage, rather than legislative restrictions specifically. Now moving on to the results. As observed from this diagram, which is the preferred reporting items for systematic reviews and meta-analysis, also known as PRISMA, the initial search yielded 3,154 articles with 111 from 1970 to 1974, and 2,333 from 1992 to 2023. After removing 4 duplicates, 2,440 articles underwent title and abstract screening by 3 independent reviewers. From these 33 articles advanced to full text review, the first author reviewed all 33 articles, resulting in 9 eligible studies for inclusion in the scoping review. The studies were categorized into 4 themes for analysis: the impact on economic outcomes, barriers to access and their economic consequences, financial burden, and legal implications of abortion. Of the 9 studies reviewed, 2 studies examined themes of women's economic outcomes. Both studies compared the economic outcomes of women who had access to abortion care and those who did not. Research indicates that women who have access to abortion experience improved economic outcomes, such as higher earnings and reduced poverty rates, compared to those who are denied abortion or live in states with restrict abortion laws. For instance, one study discovered that women who received abortions had 1,300 higher earnings and a lower likelihood of living in poverty when compared to women who were denied abortions. Moreover, the study revealed that those who were denied abortions had a higher probability of being unemployed or underemployed 6 months after seeking an abortion, with rates of 27% versus 14% for women who received abortions. Both studies found that women with access to abortion care had better economic outcomes compared to women denied abortions or living in states with restrictive abortion laws. Economic outcomes were defined in terms of earnings, rates of poverty, employment status, and access to healthcare. Of the 9 studies reviewed, 3 studies examined themes of women's economic consequences. This is defined as the indirect economic effects of having access to abortion. Specific jobs, for example, show the inequitable economic effects of abortion access. One study surveyed US servicewomen and found that 45% of the participants had to travel more than 50 miles to obtain an abortion, and 18% reported having to pay more than $500 out of pocket for the procedure. These barriers and economic losses were due to specific military policies and lack of provision of information and resources, which shows the indirect economic effects that abortion access holds. Another indirect economic effect of abortion access are the missed workdays caused by mandatory waiting period legislation. A study conducted in Utah found that women who had to wait 72 hours or longer to obtain an abortion were more likely to report missing work and losing wages compared to those who did not have to wait. 2 of the 9 studies reviewed the themes of financial burdens of abortion care on women and their families. The cost of abortion can be a significant expense, especially for low-income women. In one of these studies, many women reported having to borrow money, cut back on essential expenses, or face other financial hardships to pay for the procedure. When measuring financial burden by food, rent, and utilities, the studies showed that between 14% to 38% of women experience these types of financial hardships. The cost of abortion can vary depending on a number of factors. And while the median out-of-pocket cost for an abortion in the United States is $550, the cost can be significantly higher for women who live in states with restrictive abortion laws or who must travel long distances to access care. 2 of the 9 review studies examined legal implications of abortion. It is crucial to consider the legal context in which abortion access is situated, and restrictive policies can have significant economic consequences for women. The Dobbs decision has broader implications for women beyond reproductive rights, particularly in terms of workplace discrimination and harassment. It may make it more difficult for women to bring claims based on pregnancy or disability, hindering their ability to seek redress and impacting their career opportunities and earnings. Additionally, weakening workplace safety regulations could disproportionately affect women who already face economic inequality and are more susceptible to workplace injuries and illness. The study also highlights the correlation between abortion restrictions and increased maternal mortality rates, exemplified by the 27% increase in maternal mortality in Texas due to clinic closures. These studies contribute to the ongoing abortion rights debate, emphasizing the need to consider the legal and economic ramifications of further restricting access to abortion and aligning policies with scientific evidence and public health. Oh, there we go. Okay, sorry about that. Now moving on to discussion and conclusion. This scoping review examined the effects of abortion access on women's wages and workforce participation. It identified 9 studies that met the inclusion criteria, grouped them into 4 themes for analysis: the impact of abortion access on women's economic outcomes, barriers to accessing abortion care and their economic consequences, the financial burden of abortion care on women and their families, and the legal implication of abortion. The analysis of the themes revealed 2 distinct categories of wage loss experienced by women in the context of restrictive abortion access: direct and indirect. Direct losses encompass the adverse consequences of limited upward mobility, employment loss, and the inability to achieve one's aspirational goals. On the other hand, indirect losses pertain to the financial impact incurred due to missed workdays, expenses related to transportation and childcare, as well as out-of-pocket costs associated with obtaining an abortion. Furthermore, the studies found that women with access to abortion care have better economic outcomes, while barriers to access and the financial burden of abortion care pose challenges for women, particularly those in low-income situations. The review also highlighted the need for evidence-based policies that prioritize women's health and well-being and emphasize the economic consequences of restrictive abortion laws. The strength of the review included a comprehensive search strategy with the library informationist, along with a well-defined inclusion and exclusion criteria, meaning we took into account looking at year prior to Roe and looking at years post-Casey, which highlights the increase in state-level abortion restriction policies. The limitations of this scoping review include only using one search engine and only obtaining 9 articles. The policy implications underscored the importance of considering the economic consequences of restricting abortion access and calls for improved access to affordable care and the removal of barriers for women. I would like to thank my reader, Dr. Caroline Cardona, my colleagues Joyce Chung and Ria Gupta, and my family and friends for their love and support.
Great job, Foujan. Thank you.
Great job, Foujan. That was super interesting. So I noticed that you only had 9 articles. So I was wondering that given abortion is such a well-researched topic, how you only got to 9 articles.
Yeah, sure. That's a great question. So most of the articles when it comes to abortion, they're looking at what may cause someone to get an abortion. They're looking at factors before the abortion, and we were mostly interested in the outcomes of abortion, and that seems to be very limited. Therefore, it just highlights the importance of having to look at those factors. And even if they were looking at factors of abortion outcomes, they weren't really taking into account employment or wages. So it just highlights how important this topic is. So future research should be conducted.
Foujan, thank you for such an amazing presentation. That was really interesting to learn about. I just have one quick question concerning your time restrictions in your search strategy. How did you decide the 2 different periods?
Yeah, that's a great question. Thank you. So we wanted to look at prior to Roe, just because we knew that abortion wasn't legal on a federal level yet, but some states did have legalized abortions, such as New York and some other states. And so we thought that period was important to look at because it would show the most, it would have the most restrictions. So therefore it would show the most outcomes of having those restrictive access to abortion. And then we wanted to look at periods after KCV Planned Parenthood, because that's when states started to do undue burden policies with restricting abortion access. So that's how we identified those 2 periods of time to look at.
That makes a lot of sense. Thank you so much.
Thank you.
Great job, Foujan. I thought it was really informative. I had a question about your discussion where you talked about direct and indirect cost. And I just wanted to know, get some clarity on how you decide the breaking point between a direct and indirect cost.
Yeah, thank you for that question. It might have been a little confusing if I didn't explain it. So how we identified those is that there might be direct effects on employment and wages, and that would be through, if you're losing your job, that's a direct effect on your employment status. And if you're unable to move up in your career, that's a direct effect on your employment. And if you're unable to achieve your aspirational goals, that's another direct effect on employment. However, when we're looking at indirect effects, it's more that it's out-of-pocket costs that you're losing wages rather than more employment wage losses. So if you have to pay for out-of-pocket for transportation costs because you have to travel to an abortion clinic, or if you have to pay for childcare costs to travel to an abortion clinic, or if you have to pay for out-of-pocket for the abortion because most insurances do not cover abortion. So that's how we identify the direct and indirect causes of restricting abortion access.
Thank you. Great, interesting presentation. Following up, in terms of one of the points you raised was the limited effect, the effect this has on a woman's ability to seek redress for workplace discrimination. I wonder if you could expand on that. It's an interesting point.
Yeah, of course. So in the paper that was discussing the Dobbs decision and the implications that might have for abortion, it was talking about how if we are taking away abortion access on a federal level, then there are going to be more disproportionate, you're working the workplace safety regulations that are in place because you're taking away that clause on a federal level. Therefore, they're more likely to be punished for having a pregnancy or wanting to seek redress for harassment or anything that happens in the workplace. That's how they were describing, because if there's no protection on a federal level and it comes down to state levels, then you're weakening those safety regulations that are in place for women.
Thank you.
Right, great. I think that covers it for both folks asking questions live and in the chat. So big round of applause. Thank you so much, Foujan. We are just quickly moving on to our third presenter. So please join me in welcoming Kiersten Gillette-Pierce, who joined us at Johns Hopkins after completing her bachelor's in science in public health and women's and gender and sexuality studies at American University. And today, Kiersten is presenting on her master's essay, which is entitled "The Impact of Testosterone Therapy with and Without Oophorectomy," I mispronounced that one, "among transmasculine and gender diverse individuals, a scoping review." Please feel free to come off mute, Kiersten, and share your screen, and you can get us started.
Yes, my name is Kiersten. Some folks call me Gillette, and I'm going to be presenting on the impact of testosterone therapy with and without oophorectomy among transmasculine and gender diverse individuals. So hopping right into it, I'm going to give a few key terms and background things. So transmasculine and gender diverse individuals, for the purposes of this study, were identified as trans men and individuals who identified as masculine of center, as well as folks who may or may not identify with their sex identified at birth. Grounding us in the term gender transition, I just want us to really know that it presents as a spectrum. It's not linear, it's individualized across a person's life course. And it's way more complex than the visual appearance of like sex organs. And then lastly, hypoestrogenic state. I use this phrase in an effort to be gender inclusive as opposed to using the word menopause, but it's literally the same process. Okay, so just giving us some background, right? In the US, about 0.5% of adults report a gender identity that differs from their assigned sex at birth. And despite recent transgender health advancements, accessibility barriers still exist due to cis heteronormativity and all-around transphobic violence at the interpersonal, institutional, and systemic levels. And of course, these barriers are amplified in the case of Black, Indigenous, and people of color, as well as low-income populations. And lastly, given our current political climate, it's likely that this situation will only worsen and outcomes will become more disparate. So research like this is really needed. Talking more about the situation. So in the US, nursing programs dedicate about 2 hours and medical curricula have 5 hours max, if any hours at all, specifically allocated to LGBTQ health. This lack of content area training for providers leaves trans community members really at risk for significant health disparities, but it also really highlights that there is a need for academic research, a need for an evidence base to be built, to not only inform the work that current practitioners are doing, but also to inform the medical training and the clinical training that our current providers our training providers are going through. So with that, I know we have some clinicians in here, so I wanted to just put some grounding stuff in here, right? So when we talk about medical transition for transmasculine folks, we know that can consist of testosterone only. And we just want to note that it's medically necessary, right? Because it improves quality of life, it improves mental health, and it also improves psychological wellness. It's literally life-saving, right? So what testosterone therapy can do for folks, it will contribute to the development of physical attributes. So that relates to like facial hair, increased muscle mass. And there's also physiological changes that relate like increased clitoral size and cessation of the menses. And lastly, on the transitioning process, I can talk about like gender affirming surgeries that really have to do with surgical transition, which can be used in tandem with medical transition if desired. So despite me noting that there's like a paucity of evidence in looking at the existing literature, because there is a bit of literature, there's clear potential for adverse outcomes like related to cardiac events, as well as just the fact that there's potential adverse impacts of a hypoestrogenic state. And so that's what really drove myself and my co-authors to conduct this scoping review. We wanted to just see what's out there in relation to impacts of testosterone therapy and hypoestrogenic effects among transmasculine folks. And you can see the search strategy here. I won't go too deeply into that, but do know that we ended up with 35 articles after going over our inclusion and exclusion criteria, and we started with 2,400. All right. So grounding us further, here are some of the topics that we covered in the paper. I obviously don't have the time to go over each one of those, so I'm only going to pick 2. But I also wanted to just preface our results with the fact that, as previously discussed, there's a dearth of evidence, right? So we followed the current practice in that we extrapolated information from studies on cisgender men and cisgender women when necessary and compared it against anecdotal evidence whenever possible. And it's also very, very important to note that because long-term exposure to exogenous testosterone among trans-mass folks generates like cardiometabolic profiles, as well as overall mortality rates that are literally on par with that of cisgender men, we lead with that data whenever possible. Okay. So skipping things, I know it's a lot on this slide, but I'm going to guide you through it, right? So, okay. The current literature really demonstrates that among cisgender adults, sex hormones can act as risk or protective factors for like heart disease and diabetes. Among the research that we found, cisgender men receiving exogenous testosterone, it literally was associated with erythrocytosis, hypertriglyceridemia, lowering of high density lipoprotein cholesterol, increased salt retention, increased arterial hypertension, and acne. Interestingly so, among hypogonadal cisgender men or men with low testosterone levels, testosterone therapy decreased blood pressure and improved lipid profiles. Now, in conducting this review, we found that trans men were reported to, as I said a little bit earlier, have those cardiometabolic profiles that were on par with that of cisgender men, but there were negligible impacts on blood pressure. And then you can see here at the bottom, it also was found that the testosterone therapy was not determined to be, a factor contributing to risk for venous thromboembolism or really any adverse cardiac events. But I want to cover these three things that I have in red here, just because they were interesting. And I think there's something for future research to really pick up on. So here we have polycythemia, right? So it's a risk factor for venous and arterial thrombosis. But when you talk about testosterone exposure in transmasculine folks, it can be inflammatory and it's associated with factors that increase blood pressure and dyslipidemia, right? So this is really important because it's more likely to occur, when there's increased blood pressure or decreased HDLC, which is the case for transmasculine folks who are unexposed or exposed to testosterone. So next, endothelial function. In the case of testosterone exposure, it was found that it decreased flow mediation or flow-mediated vasodilation and caused significantly diminished endothelial function. And interestingly so, cisgender women, this is a risk factor for atherosclerosis, right? So further research is really needed to explore the relevance to folks on the trans-mass spectrum, but it's something to consider. Lastly, insulin resistance, and I'll touch on it just briefly. We want to first just say the effects of sex hormones on insulin sensitivity are not even fully understood yet across the board. So this is really jumping the gun, but there's a study that was conducted in 2021 by Louis and colleagues that really kind of gives a little insight, right? So they reported that the masculinization that is resultant of testosterone therapy in trans-mass folks, as that masculinization progresses, insulin resistance decreases. So that suggests that testosterone acts as a potential protective factor against insulin resistance and possibly even diabetes. Skipping. Okay. So moving on to the next topic that we'll cover, and the last topic that we'll cover actually, right? So gender affirming gynecological and reproductive care, we know it's necessary, we know it's life-saving, and there are certain services that are recommended so that transmasculine folks can have optimal care experiences. And I want to just note that amenorrhea or cessation of the menses will happen between 1 and 13 months, but that means nothing according to the evidence that we found in reference to like pregnancy risk, right? So if you retain reproductive organs as a transmasculine person, you have to consider pregnancy as a possibility if you're engaging in penis hole sex with partners capable of producing sperm. And that's really interesting because a lot of folks don't believe that that happens. And that's even when you're amenorrheic, like even when you're not bleeding, you still may have something happen where certain metabolic processes go on, and exogenous testosterone will alter the hypothalamic pituitary ovarian axis and produce this like, I guess you could say like atypical progesterone secretion, and that preserves ovulatory function. Again, even in the absence of menses. And that's something that I feel a lot of people overlook. Quickly touching on chronic pelvic pain, it manifests differently among trans folks compared to like cisgender women. And that's very, very important because that also is related to that ovulatory or persistent ovulation. If one is injecting testosterone and they're finding that they're having cervical pain in like a cyclical fashion, that may be indicative of the fact that you are ovulating. So really interesting things, right? We don't know the general incidence or prevalence of STIs among trans folks. It hasn't been determined, but it's also really important to consider the fact that atrophic genital urinary tissues and microabrasions really make folks more susceptible to inflammation and STI infections. And those things are very common among trans folks. So something to keep in mind for future research. Maybe we'll do it, maybe someone else will. I can quickly touch on cancer and all-cause mortality, just noting that we think about folks who are born with like gynecological organs and folks who may have like chest tissue, that they are automatically at risk for chest cancer or like ovarian cancer. But this research has told us that genetic makeup likely influences testosterone modulation of chest morphology alterations. So for some folks, it confers like protective factors and really does kind of like create these lobular kind of structures within the body that reduce risk. But for other folks, it upregulates 8 genes that are related to chest cancer causing, or that are chest cancer causing. And then relating to like cervical cancer, if you retain your reproductive organs, you can still get cancer. And a lot of folks don't think that that is the case just because they are on long-term testosterone or just having any type of testosterone exposure. And then lastly, among trans men, there's this total mortality and cause-specific mortality. There's no difference from the general population, which is really important because I feel like people try to make it seem like trans folks are not all right, and they're all right. They just need us to take their health seriously. I'm going to quickly talk about my overall recommendation. I don't know if you were able to pick up on the fact that like ovary retention is possible and encouraged in the absence of family history and ovarian cancer, and many other like estrogen-dependent diseases. And it's important because they are needed for long-term overall health, as long as you're not planning on being on testosterone for a very long time. And that really just has to do with your relationship with your provider. You can talk about those things. But without that, not retaining your ovaries really kind of confers more risk. It increases morbidity and increases risk for mortality. So that's a recommendation that we have. And then the main recommendation I feel like I've said on each slide is just there's need for more research. We need larger sample sizes. We need more diverse folks there. We need a larger variety of folks across the transmasculine spectrum being involved in these studies. We need studies with longer duration. We just need more studies. We need more studies so that we can provide better care to transmasculine and gender diverse folks who are experiencing testosterone exposure as well as low estrogen levels. Here are my references, here are my acknowledgements, and I just want to say thank you.
Great, thank you so much, Kiersten. This is a really interesting and broad presentation touching on so many different topics. I think I learned a lot.
Thank you. It was a great presentation, very important topic today. I was curious about whether the testosterone is age-related, what your thoughts are with respect to how early or late to do this. Are we doing our adolescents a disservice by holding them back until they have autonomy? Can you expand on those views? You've touched on them so eloquently.
Thank you for that question. Okay, my specific area of focus is really on adult health, but in talking about adolescent health, I believe that the current practice is to use hormone blockers, and to transition socially. Like that's the current overall practice.
Transition when?
I'm sorry, socially. So yeah.
Socially.
Mm-hmm. So we're not really discussing, according to my knowledge, we're not really discussing like a medical transition or surgical transition. It's really like a social transition. Folks just coming into their own, in very beautiful ways. As far as us, I'm sorry, can you tell me the beginning of your question again?
when you would start testosterone, how long you would use it, what clinical outcomes are you looking for before either reducing or stopping it? And also, I tack on whether you suggest oophorectomy.
Okay. So oophorectomy will only be suggested or pushed, right? Suggested if someone is having like adverse outcomes related to a chronic pelvic pain. That's normally something that will come up. And that's literally the number one reason that trans, masculine, and gender diverse folks will seek out that procedure right now. Also, we won't push for that unless they have like a history of cancer in the family related to like estrogen dependent cancers or diseases. So that's not a first recommendation, though they can be preserved and retained in the event that maybe they may want to bear children. If that's something they don't want, because a lot of folks don't want to do that. If that's something they don't want, it also just, again, reduces the burden, the morbidity burden, and reduces the risk of mortality that comes with that huge drop in estrogen levels. And if you are using testosterone, that huge drop in estrogen levels and that increased use of or increased presence of testosterone, even if you're talking about aromatization of testosterone to like estradiol, it's not enough. And the body just does not react well to that. But working with the doctor, I think, is the most important thing. I'm not a clinician, so I feel like talking with the doctor will be when you decide, do I need to come off of testosterone or different things happening? Yeah.
Thank you. That's great.
Thank you. I see I think we have time for one more question. And Emmy, do you want to unmute and ask your question?
Sure. Thanks for the very, very informative presentation. Given the current very limited state of knowledge, as you've told us, what would you suggest be added to practitioner training, either in like medical school or as continuing education? And I didn't exactly know how to say this in the chat, but let's assume that the battle to include this and that this is all judged important. So let's focus on the content. Because as I was writing it, I was thinking, well, I'm assuming that everybody thinks this is important, but let's assume. Okay.
Right. So I think understanding the cardiometabolic profiles and the ways in which they parallel is really important, because a lot of folks don't understand that. Even the amazing doctors that I work with, we were just fangirling over all the information that we're learning because we didn't know. We had no idea, and we really consider ourselves to be invested in the advancement of transgender health in this country and globally, really. So that is number one. That's number one, because that goes across so many different things. It has to do with like bone restructuring. Things change. Everything changes. Bone mass changes. Fat distribution changes. The ways in which you breathe at night changes. Everything changes. So yeah, I think that would be a great starting point.
Great. Thank you. Thank you for the presentation, Kiersten. Everyone join me in a little round of applause, and we'll take it to our final presenter. Final presenter for today's session is Tanique Bennett. And Tanique joined us actually already here at Hopkins, where she earned her Bachelor of Arts in Molecular and Cellular Biology, as well as Public Health Studies. And today, Tanique will be presenting her master's essay entitled A Systematic Review of Acceptability of STI Self-Sampling and Self-Testing among young adults in the United States. So go ahead and take it away, Tanique. We can see your slides. I could hear you a moment ago. There you are.
Hi, everyone. So my master's essay is a scoping review of acceptability of STI self-sampling and or self-testing in the United States. The main question for this scoping review is, do young adults in the United States find self-sampling and or self-testing to be an acceptable method for STI screening? First and foremost, to give some context to this presentation, I wanted to give some brief statistics about the current impact that STIs are having in the United States. According to the CDC, there were 1.9 million new STI cases in the United States in 2018, and that number increased to 2.6 million in 2019. In 2022, it was estimated that 1 in every 5 people in the United States has an STI. And this presentation will mainly focus on HIV, HPV, gonorrhea, and chlamydia. Just the incident rates for those STIs. There's HPV is 13 million, HIV is 32,600, trichomonas is 6.9 million, chlamydia is 4 million, and gonorrhea is 1.4 million. Additionally, the cost of STIs on our healthcare system is substantial, with HIV alone costing $13.7 billion. STIs disproportionately affect young adults, which is why this scoping review primarily addresses individuals under the age of 25. Barriers and risk factors that attribute to this disparity are biological factors, reduced access to healthcare, and that they are more likely to have more than one partner. The image on the bottom shows the percentage of new cases that are individuals younger than 25. As you can see, 70% of gonorrhea cases are young adults, 63% of chlamydia cases are young adults, so on and so on. Priority populations that are the focus of STI testing include Black, AIAN, American Indian, Alaska Native, Hispanic, people who inject drugs, and LGBTQ community. The graphs to the side show racial disparities for chlamydia, gonorrhea, and syphilis. As you can see, Black and AIAN individuals are disproportionately affected by these STIs. These high STI rates are particularly concerning due to the long list of health complications associated with STIs, such as pelvic inflammatory disease, ectopic pregnancies, and cervical cancer. However, due to the fact that most people who test positive for STIs are asymptomatic, screening is essential. But as we know, stigma, costs, and transportation are significant barriers to screening. A possible new solution to some of these barriers is STI self-testing. It's confidential, doesn't need transportation. People receive their results quicker, it's flexible, and it's cost efficient, especially for those that don't have insurance. However, we don't know how the public feels about it, which is why this scoping review was necessary. Important definitions to know for this presentation is self-sampling refers to self-sampling, which is also referred to as self-collection, is any test where the user has to collect their own specimens and send it to the laboratory for analysis. So you get a lot of like mail-in test kits. Self-testing are any tests that the users collect their own specimens and also test the sample themselves. HIV is typically a self-test, and other STIs are typically self-sampling. So just a review of the question: do young adults in the United States find self-sampling and or self-testing to be an acceptable method for STI screening? So for my scoping review, I primarily used the database PubMed, and the eligibility criteria, there were 7. It had to take place in the United States, published in the last 10 years. Studies had to include young adults in the population, address acceptance. Any facet of acceptance was fine. Articles had to be written in English, full text had to be accessible, and must be primary research. So here's a quick breakdown of the results. There were 19 articles that ended up being reviewed. I started off as 221 and got narrowed down all the way to 19. It was 13 quantitative, 5 qualitative, and 1 that had both. Primary locations were New York, California, and Southeastern United States. Priority populations that were addressed were Black, LGBTQ+, and people who inject drugs. So a review of the results broken down by infection. So acceptability was fairly consistent across infections. Most people found STI self-collection as a safe and acceptable alternative to clinician-collected tests, regardless of the disease being tested. So regardless of whether it was HPV, gonorrhea, chlamydia, trichomonas, or HIV, it didn't matter. Everyone seemed on the surface level to find it acceptable. There's some other disparities that we'll get into shortly. Common concerns across all infections were fear of using the test incorrectly and concern that self-sampling and or self-collected tests were less accurate than clinician-performed tests. This concern was amplified in studies discussing HIV self-testing. In terms of racial differences, in the studies that had a target population that included racial minorities, acceptance was lower. Increased concerns were about privacy as well as social support. Possible reasons for disparities included concerns about stigmatization, medical mistrust from systematic racism, and reduced access to medical care. The main conclusion, one second, I think.
We can see the slides if that
I
was.
think I skipped over something. I did. I clicked it twice by accident.
There you go.
There were also locational differences. Acceptance was lower in the southeastern United States, specifically with Black men who have sex with men. Studies found that Black MSM in the South preferred clinician testing over self-sampling and self-testing. Possible reasons for this disparity included the southern United States has higher rates of poverty and unemployment than other parts of the United States, increased stigma about STIs, and reduced access to sexual health education. The main conclusion is that self-testing is a viable tool that has the potential to increase accessibility of STI testing. While many find it as an acceptable tool, the intersectional nature of STI testing shows us that there are specific concerns in the Black community and in the Southern United States that must be addressed. Limitations to this review was that PubMed is the only database used. There was a lack of qualitative studies, and it relies on the young adult filter in PubMed. So like it's based off of PubMed's accuracy for that filter. For future research, my main concern with the articles in this scoping review is that they lack depth. The quantitative articles were very surface level. They either only asked whether the individual found STI self-testing or self-sampling acceptable, or they asked them to rank their screening preferences. The qualitative studies were better at discussing nuances, but were still rather short and surface level. Thus, there needs to be more in-depth research in the future that gets at the reasons behind STI screenings, behind STI screening preferences. Additionally, there weren't any studies that compared populations in the same study. For example, there were studies that reported acceptability rates for both men and women, but they didn't actively compare them with statistics. So there weren't any chi-square tests or logistic regressions analyzing covariates. So in the future, more analysis and population comparisons need to happen. Lastly, there were no articles in these 19 that discussed the AIAN or Hispanic community. There was also only one article about Black women. Both of these populations need much more research into their specific needs and concerns. Overall, this option for screening is fairly new and need for more quality research in order for us to really understand whether people find it as an acceptable method, and if they do, why. And that is the end of my presentation. I have my references and acknowledgements. Thank you so much for my reader, Dr. Shannon Wood, and my friends and family.
Wonderful job, Tanique. Thank you so much. Great presentation. All right, I see the chat is already filling up with lots of praise. I'll open it up for questions now. Yeah, Kiersten, I see your hand in the chat. Go ahead.
Yes, I'll ask a question. What's the most memorable thing that you learned from working on this review?
I think what strikes me about this review is the need for more research. There was just so much surface level things that were discussed that I feel like just needs a lot more analysis. And also the articles included in the study were very they analyzed one target population and didn't compare them, right? So I feel like a lot of it was interesting to have in-depth articles about one specific target populations, but it was very striking that there needs to be more comparison. So I feel like really it's just how much more that needs to be done in this field. That was probably the most striking part of it.
First of all, great presentation. I really, really enjoyed it. But I was wondering, with the impact of the COVID-19 pandemic, I know a lot more attention was paid to self-care measures, like in family planning, especially. So how do you think the COVID-19 pandemic impacted perceptions on self-testing?
Definitely, like I think COVID definitely impacted the perceptions of testing in the way that it increased education about what self-testing was. Like beforehand, you didn't really hear about self-testing. And then as COVID progressed and the public started using more and more of self-test kits and becoming more familiar with it, I think a lot of it, people are just much more aware of it as an option and are much more comfortable with the idea of doing these collections by themselves. Also, from like a funding standpoint, a lot of the funding from COVID, like I know I work for a STI testing company. Well, not testing program. It's actually Hopkins based, but our funding for COVID testing to develop new like rapid tests and COVID tests. Once we had completed all our objectives for that, the funder actually wanted us to transfer that money into STI testing. So, and I know that happened with a lot of fairly large federal grants as well. So like, you'll see this direct correlation between COVID, this surge of COVID testing into a surge of STI testing innovations.
Great, thank you so much.
Thanks for a great talk. Does self-testing, was there anything in the literature that talked about the ability to follow up for contacts and the problem that might create by not sharing the positive test information with other contacts?
Yes. So it appeared a lot more in the literature talking about HIV self-testing, just because like the psychological concerns about informing someone they have HIV, and that can't just be done when logging into a portal and being like, oh, okay, well, oh, this person's HIV positive, and reading that for yourself is you need someone to be able to talk to with, right? So a couple of the programs, if people did get positive results, they reached out to them themselves and didn't release the information until a nurse or a doctor could like talk to the patient themselves. So that was definitely a concern throughout the articles, but usually the programs ended up having a workaround.
Great. All right, so if we don't have any other questions, please join me in giving Tanique a round of applause. And a big congratulations to all of our students who presented today and all of our master's students who will be graduating this year. It was really exciting to see all the hard work you have all put in to get to this stage of the program.